Hello, thank you for being with us today. It's a pleasure to have you here in this third symposia of INSER for our international partners. My name is Juan Luis Giraldo, MD. I'm a gynecologist, OBGYN, and I'm an international director of INSER's international department. So in this next 20 minutes, we're going to talk about a really interesting subject: fertility preservation for women, the new female frontier. Every gynecologist today needs to know basic aspects about fertility preservation to be able to counsel his patients or her patients appropriately. So I hope this short talk gives you those basic issues and concepts about fertility preservation that you can use for your patients in your clinic or hospital. These are my disclosures. Of course, I'm INSER Group partner, and we do fertility preservation on a regular basis. There's two big indications for fertility preservations: medically indicated fertility preservation and elective fertility preservation. We're going to start talking about medically indicated fertility preservation. There's lots of conditions that are good reasons to think about and to perform fertility preservation in our patients. First, our oncological pathology of patients that are going to be taken to radio or chemotherapy that's going to affect their ovarian reserve. Patients with severe endometriosis, with ovarian compromise, with endometriomas that we today know that diminish ovarian reserve. Patients with genetic disorders such as Turner syndrome, usually mosaic Turner syndrome, that have, early ovarian failure, so that we can preserve that fertility for those patients before they get to that ovarian failure. And of course, patients with BRCA1 mutation or BRCA2 mutations that can be recommended to have oophorectomy during their reproductive life. Also, patients that have a risk of premature ovarian failure related to Fragile X syndrome are candidates for fertility preservation. Patients that are taken to surgery for oophorectomy due to malignancies in their ovaries or their reproductive tract, or benign pathology as endometriosis or pelvic abscesses and infections. Transgender medicine is also an area we should recommend fertility preservation. And something that's a little bit more controversial: women with low ovarian reserve evidenced by low AMH values. But cancer is becoming a real issue for us that work in reproductive medicine. In 2018, GlobalCan reported that in that year, 8.6 million women were diagnosed with some form of cancer. Most of them, the biggest part, with breast cancer, but also a good portion of those patients with cervical cancer. And the thing is that cancer incidence is on the rise in women around the world. If you can see all these countries, the incidence of cancer in women is increasing year by year. The dotted line on the right side of the screen shows the tendency, and the blue line is Colombia. Our incidence is increasing constantly. And the purple line is the USA, where the incidence is also increasing a lot. In Colombia, just in a period of 10 years, the number of cases of women newly diagnosed with cancer went from 40,000 a year in 2015 and will be 60,000, almost 60,000 a year in 2025. In a period of 10 years, it increased 50%. But many women, of these women that are diagnosed with cancer, are in the reproductive age, women under 45 years old. Almost 10% of women with cancer are in reproductive age. And approximately 100,000 women in reproductive age will be diagnosed with cancer this year in the USA. 1% of all the cancer diagnosis is made in children. And in these cases, of course, fertility preservation is something to talk about. But as cancer incidence goes up, the cancer mortality goes down in women. Medicine has lots of advances, fortunately, and we see that these patients, this woman diagnosed with cancer, survive more to cancer each day. As you can see in these countries, and the dotted line, that's the tendency, and the blue line, that's Colombia, and the purple line, that's the US, the mortality is constantly diminishing. And that's why 80 to 90% of adolescent patients and young adults survive cancer in Europe and in the USA, but of course, with consequences in their fertility prognosis. In the last 5 years, overall mortality of cancer has diminished constantly 1.6% per year. So we can conclude several things from this. First, that the number of women with cancer is on the rise. Second, that the number of female cancer survivors is on the rise as well. Third, that cancer treatment focus is increasingly on quality of life after cancer because we have more survivors. And finally, that fertility is a fundamental aspect to consider when talking about quality of life. So when we see oncological therapy, which ones are the most deleterious or which ones affect the most the ovarian reserve? Mainly pelvic radiotherapy. That's the biggest one. And on the second place are alkylating agents in chemotherapy, just as cyclophosphamide. So those two are the big enemies. And what does chemotherapy does on ovarian reserve? Well, the induced damage in the ovary by chemotherapy is caused by the loss of primordial follicles by apoptosis, by the enhanced follicular atresia, by the inflammation and damage of the ovarian stroma, and by the damage to the intra-ovarian vascularization. But there's one thing that's really interesting. Remember that chemotherapy affects and kills cells that are reproducing or growing pretty fast. So antral and preantral follicles fall into that classification. So chemotherapy goes in and takes those preantral and antral follicles pretty fast into apoptosis, into atresia. And those follicles are the ones that produce the anti-Müllerian hormone. And the anti-Müllerian hormone is now known to be one of the most important agents in the regulation of the primordial follicle recruitment. So when the AMH levels fall, because those antral and preantral follicles in that patient with chemotherapy go into atresia, the recruitment of primordial follicles increases. So we have an accelerated primordial follicle activation. And that's why we lose a lot of this pool of primordial follicle during chemotherapy in patients with cancer. But this can be a nice conclusion. Well, not nice because of what it says, but nice to get an overall idea of what chemotherapy does on ovarian reserve. After chemotherapy, a woman's ovarian reserve will behave as if she was 10 to 12 years older. We need to have that in our mind. That's why patients of 38 or 40 years old that go to chemotherapy for breast cancer, 80 or 85% go into premature ovarian failure after that chemotherapy. But what about elective fertility preservation? This is what women today are living. They're living in a dichotomy. They don't know if they want to be first good moms and then good professionals, or first good professionals and then good moms. Usually those two conditions don't get along each other that well. So it's a really difficult condition. That's why we're seeing this each time more oftenly, okay? And it's gonna be knocking on our doors in the near future. Because childbearing age in women worldwide is increasing constantly. If you see in Europe, in the last approximate 20 years, the average age of childbearing for women has increased almost 4 years. 4 years in the reproductive span life of a woman is a really, really important time. And this is no secret for any one of us in this meeting. Fertility has consequences regarding age. Women acquire their maximum fertility potential between 20 and 25 years old. At that point, they kind of stabilize up to 30 years old. After 30 years old, fertility potential starts to diminish. It's not that noticeable until 35, but after 35, that diminish in fertility potential starts to decrease really fast. And after 38, well, it plunges down. And otherwise, on the other hand, the possibility or the spontaneous miscarriage rate increases definitely with age. So it definitely affects fertility potential and the ability of women of advanced reproductive age of finally having a live newborn. But since we're seeing that women of higher reproductive age are trying to get pregnant, so of course, a percentage of those women are going to get pregnant spontaneously. Which ones? Probably the ones that have a better ovarian reserve at advanced reproductive ages. Those are the ones that are going to get pregnant spontaneously. So their daughters are probably going to get from their mothers genetically that capability of having a good ovarian reserve at advanced reproductive age. And they're going to get pregnant at advanced reproductive age, and they're going to have daughters with good ovarian reserve at advanced reproductive age. So this is how evolution works, okay? So finally, the window of fertility potential of a woman, it's going to be expanded through the years as we go up in the childbearing age average worldwide. But how long will this take? So this group in McGill University in 2011 did a really interesting research. They tried to detect the speed of biological evolution. So they used a really interesting model. They used fungi that reproduced in a matter of hours and therefore allows you to see generational change much faster than any other species. So they got a robot that worked 24/7 for several months, generating an environmental stress to a fungi culture by increasing the salt concentration. And they saw and they concluded that the evolutionary changes were verified to adapt to the environment in approximately 50 to 100 generations. So that fungi could develop the ability to survive to those hostile environmental stress conditions after 50 to 100 generations. So if we extrapolate that to humans, in humans, each generation is considered to be approximately 25 years. So that would mean that for a woman to be able to start having, well, good fertility rates at advanced reproductive age, it will probably take 1,250 to 2,500 years. Not practical. So that's why we need to develop strategies for fertility preservation. And we've done that. If you see from 2012, the number of cases of fertility preservation in the US reported by the ASRM was 3,000 per year. 4 years later, in 2016, that number increased 300% to 9,000. And in 2020, ASRM reports approximately 24,000 cycles of fertility preservation with oocyte or embryo banking. So it's increasing definitely. It's something that's permeating to our society. And this made a whole big difference. Why? Because we've been cryopreserving cells for many years now. The first sperm cell cryopreserve was 1953. But the classic cryopreservation methods are done by slow freezing, by turning the tissues into ice. And the big problem is that the ice that forms inside the cells have sharp edges that can damage the organelles of the cell, mainly the meiotic spindle. So the secret for slow freezing for conventional cryopreservation is to dehydrate the cell. Meanwhile, the temperature is taken down slowly to avoid the formation of those ice crystals inside the cell. So the cells that have the biggest quantity of liquid inside are the cells that give us the more difficulty to be able to be cryopreserved. And well, it happens that the egg is the biggest cell in the body. Of course, the one that has the most liquid inside. So oocytes have been very inefficiently cryopreserved with conventional slow freezing techniques, with very bad survival rates, until really bright groups decided that they were going to try to avoid those ice crystal formations inside the cells. They were going to turn those eggs into glass instead of turning them into ice. So vitrification was formed and was born. And vitrification consists of putting the cell in high concentrations of cryoprotectants and plunging the cell, the oocyte, fast into liquid nitrogen to have a really fast decrease in temperature. So you vitrify the eggs that way. And when you want to use those eggs, you warm the eggs. And the survival of oocytes with vitrification is extremely good, between 85 and 90%. So it made a big difference in terms of female fertility preservation. Actually, the first baby reported with slow freezing conventional techniques from a frozen oocyte was in 1986. But up to 1996, the results were pretty bad. And many groups attempted to obtain pregnancies from these eggs and couldn't make it. The first baby with vitrified oocytes was 1999. And basically all groups report now oocyte survival after vitrification and warming around 85 or 90%. Actually, in 2013, ASRM removed the experimental label for oocyte vitrification based on similar results obtained in terms of pregnancy rates with vitrified versus fresh oocytes. In 2014, ASRM and Canadian Fertility Society introduced the concept of elective oocyte preservation without medical indications. And today, most of the oocyte cryopreservation or fertility preservation cycles are done for elective purposes or for social reasons. Only 12% are done because of a medical indication. At INSER, we see exactly the same. In 2020, 41% of our fertility preservation cases were due to medically indicated fertility preservation. But 2 years later, that 41 turned into 23%. And most of our cases now for fertility preservation are elective fertility preservation cases. Fortunately, we learned that the ovary does not have just one wave of follicular development during the menstrual cycle of a woman. We now know that it has 2 waves or even 3 waves. So today we can start control of our hyperstimulation protocols or ovarian stimulation protocols with GnRH antagonists at any day during the cycle. That's called a random start, as long as we're not going to do a fresh embryo transfer, of course. But this allows us to start that patient with an oncologic diagnosis that needs to start her treatment pretty fast. We can start her right away, independently on the day she's on her menstrual cycles. And it's only going to delay her treatment for 12 to 14 days. And we know that pregnancy rates are similar today with cryopreserved or vitrified eggs or vitrified embryos. so we can choose whatever we want. Of course, embryos have some ethical implication because it's not the same thing to discard eggs than to discard embryos in case those are not going to be used in the future. And today, the conclusion in egg cryopreservation is that the clinical pregnancy rate is going to be 6% per vitrified egg. So each vitrified egg is going to give us a 6% percentage of pregnancy rate in women under 35. So if a woman has 15 oocytes, her cumulative pregnancy rate is probably going to be around 85%. So it's a good chance of making it. And Dr. Cobo from the Instituto Valenciano de Infertilidad published in 2021 this interesting retrospective paper that included approximately 1,500 women that had electively cryopreserved eggs for fertility preservation. And this woman came back to use those eggs to get pregnant. And something really interesting appeared. If women were younger than 35 years old and they had at least 15 eggs, their cumulative pregnancy rate was as high as 85%. But if the patient was over 35 years old and had, let's say, 10, 11 eggs, her cumulative pregnancy rate was 35%. So there's a big difference between doing elective fertility preservation with vitrification of your oocytes if you are under 35 or over 35. We now have good tools to calculate the possibility of a patient of having a live newborn with fertility preservation techniques, with vitrification, with egg vitrification, and these tools give us that possibilities according to age and the number of vitrified eggs. But if there's no enough time to vitrify eggs, you always can freeze ovarian tissue, mainly in patients that need to start their oncological treatment right away for some reason, or in prepubertal girls that cannot be stimulated. So in that sense, you can go and through a laparoscopy, you can get small fragments of the ovarian cortex to cryopreserve. As you see here, those are really small portions of the cortex of 1 millimeter, really thin pieces of ovarian cortex, and they can be cryopreserved usually by slow freezing techniques. And when that patient has gone through treatment and is declared healthy and as survivor of her oncological diagnosis, she can have an ovarian cortex transplantation. And that ovarian cortex transplantation can be done in the ovarian medulla, or it can also be done in a peritoneal pocket orthotopically in the pelvis, the pelvic wall of that patient. But everything in medicine has pros and cons, as everything in life. So what are the pros of ovarian tissue cryopreservation? First, there's no delay. You can do that in 1, 2, 3 days, and you don't have to delay the initiation of the oncologic treatment in that patient. Second, there's no need for controlled ovarian hyperstimulation. You don't have to do ovarian stimulation for that patient. Third, you can use it in prepubertal girls that cannot be stimulated in terms of COH. And fourth, that it not only restores fertility, but also restores endocrine function. That patient is going to have spontaneous ovulation again, and will have menstrual cycle again, and will have endogenous estrogen production again, with all the positive aspects that can be related to that endocrine function. But the cons are that there's a metastasis risk in that transplanted tissue, mainly when the oncological diagnosis is leukemias, breast cancer, or ovarian cancer. And of course, you're going to need 2 surgical steps, one to get the cortex and one to transplant the cortex back to its place. Approximately 50 to 90% of the follicles are lost in this transplanted tissue. And that we lose those follicles basically due to ischemic damages and hypoxia prior to established angiogenesis. Nevertheless, more than 200 live births after orthotopic ovarian tissue transplantation has been reported up to 2021. Ideally, orthotopic. It's had the best results. Pregnancies can be obtained spontaneously or through IVF. Most of the pregnancies that have been reported have been spontaneous pregnancies. And the ovarian tissue transplantation is said can be done 2 years after treatment completion due to decreased risk of recurrence in that patient. Ovarian function restitution is achieved in almost 95% of the patients. Most of them have restored ovarian function, and usually during the first 4 to 5 months after ovarian tissue transplantation. And that ovarian activity and endocrine function is going to last approximately 5 years. After 5 years, there can be a new ovarian tissue transplantation, and there's going to be endocrine function for another 5 years. So that's a good point. And finally, almost 30% of pregnancy rate has been reported basically by experienced group in ovarian tissue transplantation. You can see here the behavior of FSH levels after ovarian tissue transplantations. As you see, most of the patients have normal FSH levels after approximately 4 to 5 months, counted from the moment they were transplanted. But also, there can be a heterotopic ovarian tissue transplantation. Most of the cases have been transplanted to the forearm or the abdominal wall. Controlled ovarian hyperstimulation with follicular aspiration and ICSI is obviously required in all these cases, and very few cases have been reported. Orthotopically has had the best results. Heterotopic is an option, but it's not as good as orthotopic. And this is really interesting. Dr. Dolmans and her group in 2021 reported that there was no decrease in pregnancy rates when the ovarian tissue freezing was performed after chemotherapy was completed. So today, it's a good practice to obtain that ovarian tissue in patients with leukemia that, remember, have a high risk of metastasis in the ovarian tissue. So it's better to obtain that tissue after chemotherapy has been completed in these patients with leukemia. Other option is in vitro maturation of oocytes. That means to do follicular aspiration without controlled ovarian hyperstimulation or with minimal controlled ovarian hyperstimulation of 1 to 3 days. Do a trigger with HCG 36 hours prior to aspiration. Culture those eggs in culture media with FSH and LH to achieve in vitro maturation of those oocytes. And these decreases the time to oncological treatment initiation because that patient can be aspirated right away or after 1 or 3 days of ovarian stimulation. It prevents also elevated estrogenic levels in patients with positive receptors in breast cancer. But unfortunately, the results are really irregular and inconsistent. You can say that the pregnancy rates with these techniques are going to be probably 50% of the pregnancy rates achieved with conventional IVF. But you can not only in vitro maturate eggs, you can also in vitro maturate follicles. Follicles that are isolated or cultured from in vitro cryopreserved and thawed ovarian tissue. And these with the objective of avoiding autologous transplantation of ovarian tissue with potential content of malignant cells. So in that case, what you do is that you thaw that cryopreserved ovarian tissue, you isolate primordial follicles from the ovarian cortex, you grow those follicles and culture those follicles in vitro until you reach antral stage. And at that point, you remove the oocyte and do in vitro maturation for oocytes until you have metaphysed 2 oocytes that you can fertilize through ICSI and obtain embryos. No pregnancies yet, but interesting for the future. So this is a fertility preservation algorithm. It's kind of simple. If you have a patient that needs fertility preservation for an oncological diagnosis, so you can go ahead and do ovarian stimulation if you have time. And you obtain oocytes, and those oocytes, you can vitrify them, or you can fertilize them to form embryos and vitrify embryos. If you vitrify embryos, when you thaw those embryos, you can replace them or transfer them to that same patient or to a surrogate mother. Or if you vitrify oocytes, you may warm those, fertilize those through ICSI, form embryos, and transfer those fresh embryos to, well, the patient or to a surrogate. Of course, if you don't have that much time, you can try in vitro maturation. That's another possibility. Form oocytes and go to the same procedure or protocol. Form embryos or vitrify oocytes. Or if you don't have even 3 days, you can go ahead and do a ovarian biopsy, obtain tissue, obtain ovarian cortex, and cryopreserve ovarian tissue for later autotransplantation. That can be a good option also in prepubertal girls. Of course, regardless of the technique you're going to use, there's 2 things that you can do to diminish the damage because of radiotherapy, of chemotherapy in those patients. First, ovarian transposition if that patient is going to have pelvic radiotherapy. And second, the use of GnRH analogs that diminish apparently the damage of chemotherapy to the ovaries. That's a little bit controversial, but nothing's going to happen to the patient for using GnRH analogs. Meanwhile, she's doing chemotherapy. And this is a little bit of the future. So what is on our scenery in the, well, long-term future? Probably the formation of artificial ovaries. And the formation of artificial ovaries to avoid transplanting ovarian stroma to that patient and avoiding metastasis. So in that case, the primordial follicles are obtained from the cryopreserved ovarian tissue, and they are placed in a scaffold of biomaterials, collagen, fibrin, and form a artificial ovary that then is transplanted orthotopically to that woman. That's going to be interesting. And the other possibility is the formation of oocytes from induced pluripotent stem cells that you can get them from mesenchymal cells, form primordial gem cells, and from those primordial gem cells form eggs. And of course, also the formation of oocytes from oogonial germinal stem cells. So those are 2 things interesting in the future. To conclude, knowledge is power. It allows us to foresee the future and prepare for it. This was said by Louis Pasteur, and I think it's pretty bright. This is our group. It was really interesting to be here with you today. Please send us all your questions. We'll answer them at the end. And well, we'll be here happy to help. Thank you very much.